Hello, my name is Dr. Sivanvesh, consultant critical care physician, James Hospital, Ragolu, Srikakulam. Today we are going to discuss how to do prone ventilation for a severe ARDS patient. Now we are going to discuss the three phases of prone ventilation. In phase 1, we will check the all lines and tubes and airway breathing circulation.
In the airway, we will be checking about the endotracheal tube. It is patent and connected to mechanical ventilator. In the breathing, we will be checking about the ventilator tubes. Breathing circuits are connected to ventilator. After that, we will be checking about the saturation probes. Probe is connected and saturation is maintained. After that, in the circulation, we will be checking about the central line. In the central line, all sedatives are going and circulation, BP and heart rate are normal.
Now we will start the preparation of the patient in phase 2.
First, we will be removing the headrest. After that, we will be removing the pillow.
Except for endotracheal tube and endotracheal tube connection like these breathing circuits, these both are essential lines. Then we are going to remove connections for central line, arterial line and Foley's catheter.
Now we are disconnecting the central line, arterial line and Foley's catheter. Prior to proning position, first I will keep one hand below at the neck and one hand to the chin region and move the head, and to avoid the dislodgement of the endotracheal tube and to prevent kinking, to maintain the patent airway, I will be shifting the patient in the prone position.
Now we are placed the undersheet beneath the patient. Before doing prone ventilation, we will tuck the hand beneath the buttock so that no hindrance during prone ventilation. Now we are going to place the two pillows. One is at the level of chest and one is at the level of pelvis. And we already placed the undersheet beneath the patient. Now we are going to place the upper sheet, and both sheets will roll over and pack the patient for prone ventilation. At the count of 3, we are going to pull up the patient. 3, 2, 1. We are going to pull the patient one edge of the bed towards the ventilator. Now we are going to turn the patient to 90 degrees. During this time, we will hold for 3 seconds and we will check the saturation and all lines and tubes. Then we will turn the patient completely. Please prone the patient and ensure all circuits, lines, tubes are properly aligned and check for any leakages.
After placing the patient, now we will be removing the upper sheet and check for the airway. Endotracheal tube is correct in placement and secured, and breathing circuits are connected and all vital parameters are stable. Now we will be connecting the ECG leads. After correct placement of the patient in the prone position, now we will be keeping the head pillow and head ring below the patient head so that we can prevent the dislodgement of the endotracheal tube and prevent the kinking of the endotracheal tube, so and even prevent the source of the head, pressure source of the head.
Now we are going to place the patient in swimmer's position.
Now we are going to place the water gloves at the level of pressure points to prevent any bed sores or to maintain adequate circulation.
Now we completed the phase 3 of prone ventilation. Now all vital parameters are stable, all lines, tube and all connections are open. Now we completed the whole process of prone ventilation. Now we are going to supine the patient. Before that, we are disconnecting all lines and connections from the arterial lines and central line. Before supination, we are going to remove head pillow and head ring. Then we will pull the patient to one edge of the bed. Then we will turn the patient. After supination, now we are going to connect the arterial line and central line connections and Foley's catheter connection and pulse oximeter connection. Then we will check the all vital parameters. We will ensure airway, breathing, circulation all at the normal parameters level. The main aim of the prone ventilation is to improve oxygenation to some dependent areas as well as some darkest areas in the lung that are less oxygenated and ventilated. This is to improve ventilation and perfusion mismatch. And also during supine position, the patient has more burden on the lungs due to weight of the heart and other mediastinal structures, due to which more workload on the lungs and oxygenation and ventilation will decrease due to this factor. Now due to pruning, the load on the lungs decrease as heart and mediastinal structures have no gravitational impact on the lungs, due to which there is improved oxygenation and ventilation, and also less burden on lungs and improved oxygenation and ventilation to darkest areas and dependent areas of the lung. And the biggest advantage is there is an enhanced clearance of secretions in the lungs and also more homogeneous distribution of stress and strain throughout the lungs, and this leads to reduced chances of ventilation induced lung injury. Now my question is, when do you do prone ventilation? When patient has any severe ARDS after intubation or severely hypoxemic patient, as early as possible we should prone the patient. Then after proning, how many hours of prone ventilation will required? At least minimum of 16 to 18 hours per day is required. Then question will come, how many sessions of prone ventilation was required? This is until standard criteria meet. That means after supination, if patient has improved oxygenation and ventilation that standard criteria made, up to we should prone multiple sessions. Then what are all precautions we will take during prone ventilation? As we told prone ventilation before, we will take care of the prevention of dislodgement of endotracheal tubes and central lines and arterial lines and HD catheter and Foley's catheters, and also we will ensure prevention of pressure source. What are the contraindications of prone ventilation? Absolute contraindications are unstable spine fracture, unmonitored increased intracranial pressure. Relative contraindications are open abdominal wound, polytrauma with unstable fracture, pregnancy, severe hemodynamic instability, facial trauma, or facial surgery in last 15 days. We are looking forward to make more videos. Please kindly subscribe and share GEMS YouTube channel. Thank you for watching this video.